Good morning, good afternoon, good evening. Wherever you are on the globe, you are welcome to today's sessions. So we're kicking off, and my name is Rekia Saidu, and this is my co-host today.
I am Tutu Somjala. Good morning, good day, and good afternoon. We are going to quickly move to the first session today of the day in this stream, and it is ABC Global Alliance Communication Skills Training. And I will hand over to the facilitator of this session, and over to you.
Uh, Good evening from Sydney, Australia. My name's Fran Boyle. I'm a medical oncologist working in breast cancer and also at the University of Sydney in communication skills research and training. Hopefully, what we have prepared for you tonight will be thought provoking and give you some ideas of things that you might wish to change in your practice, and also, I think, a very fertile area for research. And so, very happy to communicate, of course, with everyone after the event if that is of ongoing interest. So to introduce our panel, we're going to start initially with an intro from Fatima Cardosa. Fatima will be well known to those in the breast cancer world as the champion of advanced or metastatic breast cancer patients and their needs, and probably fair to say almost single-handedly coerced, cajoled, encouraged the world's oncology fraternity to take as much attention and pay a serious attention to the needs of this group of patients as we do in early breast cancer. And she's the mother of the ABC Global Alliance and also just finished the ABC conference, which was virtual this year. So from Champollion Cancer Centre and the ABC Global Alliance in Portugal, Fatima Cardosa.
Hi. Hello, everyone. Welcome to this session. It's my pleasure also to welcome you for the ABC Global Alliance Communication Workshop. I would like to start by thanking Fran for agreeing to do this workshop for us, and also to all our panel members for being here and sharing their knowledge and experience in this such a crucial topic as communication in advanced breast cancer. I will be very brief to leave all the time possible for the panel and for Fran to share with you some very important tips on communication. So Fran, do you mind moving one slide? Thank you. So just a few words about the Global Alliance. We have started almost 15 years ago, developing specific guidelines for treating advanced breast cancer patients. That seemed very obvious that we need those guidelines, but at 15 years ago, they were very scarce and only a few countries have them. So we built this international consensus conference where patients are treated as peers, patients and patient advocates, and all together with physicians and researchers, we started to move the field faster to improve the lives of these patients. And then we saw that there was a true need all over the world. And that's why we created this global alliance that now has, as you can see in the map, almost 200 members from 90 countries around the world. And the words that really show what the alliance do is get together, collaborate, and share resources and knowledge, not to start all over again. And that's one of the goals of this communication workshop, is share knowledge and resources so that you can just use it and not start from scratch. Next slide, please. So I would like to invite you all to visit our website and to see two of the awareness videos. So we had a first awareness campaign around the problem of stigma. And this is the video that we have done called I Am Advanced Breast Cancer. So I would ask you to please go and see the video. And next slide, please. And we have just, click one more, please. And we have just launched this weekend the new awareness campaign video, and this time it is about working with advanced breast cancer. And this is related to the problem that many advanced breast cancer patients have of losing their jobs and the consequences, both psychologically but also financially, of losing their jobs. And we're fighting around the world for protection of the professional life and also the financial protection for people living with advanced breast cancer. So please go to our website, look at the video, help us share the word, and also look at our wall of stories. And if you have anyone who would like to share their experience, we are collecting more and more stories for our wall of stories. And I think, friend, this is my last slide. Oh no, last is just to show you the dates of our next conferences, because we had ABC6 virtually due to the pandemic. We're thinking about holding a special edition next year in Lisbon so that we can see each other, be together, something we haven't been doing for the last 2 years. So we'll have that ABC 6.5, and then we'll have our normal ABC 7 that will be in 2023. So I hope that some of you can join us in Lisbon for the conference and the guidelines. So enjoy the workshop, and back to you, Fran.
Thanks very much, and thank you for bringing us all together, which has been a great experience. So I'm going to introduce my panel to you. Some of them will be well known. Peter Velsteke from the University of Botswana Breast Cancer Unit, and Peter's a medical oncologist. We have Dorothy Duploy from the Cancer Association of South Africa, and she has a nursing background but works as a patient advocate as well. We have Gertrude Nakagudi, who is from the Uganda Women's Cancer Support Organisation, so a patient advocate, and Runsi Shadebi from Project Pink Blue in Nigeria, and Runsi is a psychologist. Gloria Orji from Abuja Breast Cancer Support Group is a patient from Nigeria and an advocate. And we have one other member, Eunice Mirakua, who may join us in a little while. So what I'm going to do for you today is just talk through some of the background research and science around communicating in advanced breast cancer, and to link the experience of our panel members to your specific circumstances as we go along. And I'm going to start by just identifying some of the communication challenges that patients will have in advanced breast cancer. And I think you could probably substitute advanced any kind of cancer, although there are minor differences, of course, depending on body parts that are involved. But the clarity that the patient needs to have to make sensible decisions, that their diagnosis is of incurable cancer by and large, is something very important. And yet we always worry in this context, are we taking away hope if we are really clear about the fact that the cancer is incurable? When we give bad news to patients, emotional reactions are expected and can be very varied. Giving information about treatment options may be influenced by the resources that we have available to us, and also the costs to patients and family members and to the healthcare system of those choices. Working in a multidisciplinary team, I think, is the ideal for patients with advanced breast cancer just as it is in early breast cancer, but the team members are often different. They may include palliative care, different kinds of surgeons, rather than breast surgeons, and particularly psychology, social work, and supportive care. Patient decision making being optimised is, of course, our goal, but sometimes patients make decisions that are not what we would have made, and still managing to provide support then is very important, quite challenging. Families, caregivers, and spiritual leaders, as well as communities, are often willing to support patients, but don't always know how, from as simple as not knowing how to take a temperature and how to make that phone call about the febrile neutropenic patient, to interactions with traditional healing and with traditional medicines, and that's certainly something that we see in our multicultural Australian context. Clinical trials, again, something we aspire to for these patients, and yet they add a level of complexity to the conversation, and referring to palliative care is one of the biggest challenges that our oncologists face. In some ways, knowing when to stop is just as important as knowing when to start chemotherapy. And if you don't have good access to palliative care and pain medicines, then again, that's a different kind of problem. And underlying all of this is if we wish to take good care of these complex patients to whom we become, I think, very attached, we need some self-care strategies for health professionals, and Leslie Fallowfield and others have written about this in a paper that we wrote following the last ABC workshop, which included people from around the globe. So lots to talk about, and we won't unfortunately be able to touch on everything tonight, but hopefully you'll be able to take home some practical strategies. Now, I have here the hourglass, and the elephant inside the hourglass reminds us that one of the biggest difficulties we face is time to do all of these things. And so I'm also hoping that we can share some ideas about making consultations efficient as well as productive for patients and for families. So one of the rubrics that we use and teach to our medical students and to our oncology trainees in Australia and around the world for breaking bad news and navigating those difficult conversations is a protocol originally devised by Walter Bale and Rob Buckman. Wrote about this in 20 years ago now, and it's recently been updated to adapt to the circumstances of telehealth in 2021. And this protocol is called SPIKES, and that I think means two things. One is that these conversations can be spiky and uncomfortable, but also if we were climbing a mountain and setting ourselves a difficult challenge, we want to be well equipped with the things we need, and that might include a pair of spikes on our feet. We'll work through each of these in turn, setting the scene, understanding the patient's perception of what's going on, inviting the conversation to begin, giving knowledge of what's going on, responding with empathy to emotional reactions, and most importantly, when we come to summarise and step forward into the next phase of treatment, that we haven't been speaking over a significant emotional reaction of a patient and a family member so that they were not able to hear what we were saying. Some research that we've done in Australia with simulated consultations suggests that this phase, the empathy phase, takes at least 3 minutes. And so if you're someone who likes to watch your clock, shutting up and not summarising and talking about treatment options while someone is very distressed at the news would be a wise manoeuvre, because mostly you then find that patient recall is diminished and you end up having to say it all over again or find someone else to help you. So let's move through each of these in turn and think about some examples that you could adapt to your circumstances. The first one is setting up and checking perceptions. And when we think about consultations, the key thing is listening, being able to hear the patient's point of view and respond appropriately to that. So here we have a consulting room set up with a desk and a patient, doctor and patient both on the same side of the desk, rather than, as we might have seen in years past, opposite sides of the desk, where it's very difficult for the doctor to reach out, touch the patient if they're upset. This is something that possibly works better woman to woman, or from a male oncologist to a female patient. And again, we'll have cultural nuances, because in some circumstances, very direct eye contact is considered to be inappropriate, and that is the case with our Indigenous population in Australia. So however you set up your room and your space or your telehealth, listening is the key thing. So if you can't hear, it's not going to work. If the patient can't be heard, it's not going to work. So that's the first thing to think about. Then when we're checking perceptions, some of the things to consider is, what does the patient already know? Have they come to the oncologist from a surgeon who's very familiar with what we offer? We might already have been primed with the knowledge that the cancer is spread, or are they someone who's still expecting an operation for a locally advanced cancer? What level, not just of literacy generally, but health literacy, are they likely to come from? Are there translators available? And in some circumstances, could telehealth work for some of these consultations? In Australia, it's suggested that post-pandemic, while we've learned a lot about this, we try to avoid consultations over telehealth with new patients, and in particular when there's an expectation that bad news might be given. But routine follow-up might be an alternative that could be still useful. So I'm going to just go to the panel here. And I know, Dorothy, this is something that you're very passionate about, the role that is very critical of interpreting and how we might be able to use some good strategies in that regard.
Yes, thanks, Fran. Yeah, I think that it's important that we speak in the language that the patient understands, but it is a challenge when you have a patient that, in South Africa, we've got 11 official languages, and you try and match the patient to the staff working in oncology, and it sometimes works to have either the social worker or the nurse working in the oncology department being able to interpret what the doctor is needing to tell the patient. Not always possible. We know that there's budgetary implications for state facilities where a translator is needed. The other challenge you have is that if you have a translator, the message can somehow get lost, and the interpretation of what the oncologist is saying from a third person perspective is a challenge. And we do think that the patient should be able to leave the consulting room understanding what is being said and basic information. So yes, it is a challenge in the sense that when we've got patients coming from outside of a treatment area, who is predominantly, example, speaking another language, one of the 11 official languages, but the treatment center doesn't cater for that. That is a challenge for us in that sense, Fran.
And you mentioned, Dorothy, that you have telecounselling available in a number of languages as well. Is that the sort of thing that a patient could access if the doctor had at least written down the key elements, even if that's in English, the key elements of the consultation, so the patient at least had something in writing about what's being discussed
Yes.
to then discuss again with a telecounsellor?
Yes, so what we did as an organisation, I'm from the Cancer Association in South Africa, is that we set up a telecounselling line in 7 of the 11 official languages. And it helps that the person on the other end of the line understands what the patient is saying. So we've also then went the route of forming relationships with the treatment hospitals so that the referrals coming through is also being able to translate for the patient what the doctor is saying. And if the patient has a telecounselor that speaks the same language, it goes a long way for the anxiety and everything that goes with the cancer diagnosis. So yes, so we've set up a telecounseling line in 7 of our 11 languages, and the patient, it's no cost to the patient. The patient calls in, it's a toll-free line. We call them back, the social worker, the counselor, who call the patient back in and make an appointment and take it from there. And we found that this does help.
Thank you.
Yeah.
Well, and just avoiding confusion, really. And Peter,
Yes.
you were concerned about the role of the language that health professionals are speaking, and not only could that be with an accent, with accented English, or a mixture of accented English and medical jargon all mixed in together. Do you think that's an issue in some locations?
Yes, thank you, Fran. Yeah, it can be actually, and in quite some African countries, the healthcare workers that work in that country are not necessarily native from that country and are there on a temporary basis. So sometimes language really is a problem because it has to be translated several times until it gets to the patient. So I think it is important that a hospital or a government that hires healthcare workers from abroad because there's a need and it's a good thing to do, actually also provides the budget that the translation can happen. For example, by translators or by having nurses that are from the different parts of the country and that know to speak the language and then translate whilst the consultation is being done. I think it's important because the investment is there, but it's just that little bit of translation investment that has to be accounted for.
Thank you, Peter. And we certainly have experience using telephone translators in Australia. And you can link them in on telehealth as well, either by phone or on Zoom or WhatsApp. But one of the challenges is they don't always translate what you say. And so we're going to go further now to talk about who else might be in the room when you're setting up these conversations. And when we're sharing bad news, it has become the norm in many places that family members would be invited to be with the patient. That has been difficult during COVID because of restrictions on hospital visits, etc., clinic visits. And also providing support potentially from other healthcare workers and breast care nurses traditionally in Australia worked in the early breast cancer setting, but now with increased funding, they can work in advanced breast cancer as well. And I wanted to ask you, Ronsi, how important do you think it is that family are included from the beginning in these discussions about diagnosis and treatment?
Okay, thank you very much, Fran. Families are really, really important, especially in Nigeria, and I think in most African countries where the communities are less independent. The communities are more sort of, people are sort of more living together, like there haven't been this sort of independence or the form of urbanization that, that is being seen in other parts of the world, right? So the family become a very important, factor in who is going to be in the room. But more importantly, apart from that, financial toxicity. Who pays the hospital bill is such an important factor in determining who will be in the room. So in Nigeria, for instance, less than 5% of Nigerians are covered by insurance. So cancer, it's really like almost not covered. So if some family members are the one that will have to be responsible for the care of the patient, it's almost impossible that the family will not be involved in the decision making. of the patient, or also hearing about the bad news. So it's really a very serious issue. But also, in some regards as well, we've also seen our patients refusing to share, refusing to allow their families to be in the room, refusing their husband. We have a patient that refused her husband knowing that she had breast cancer, and her reasons are valid. And we respected her privacy, we respected her. She said if her husband knows, her husband will leave her, because she's had so many people that their husband left because they had this diagnosis. And she had this for almost 7 years. So these are, some critical issues, but sometimes, right? Sometimes, you were talking about listening to patients, and sometimes we hear patients, but sometimes we don't listen to them. So we need to, and also, again, sometimes we talk to patients instead of talking with them. So I think healthcare workers need to support patients by, understanding that when they were in medical school, studying, that most of the patients were in the farm planting cereals, or probably in the market selling wares. So it is important to understand that it's so difficult for patients to clearly understand the issues and their care if they don't give them sufficient time to digest the information that is being shared.
And time, very important. And Gloria, would you have some thoughts about this subject, about women needing their family support, but sometimes being frightened of losing that? Or Gertrude, maybe? Gloria, go ahead.
Thank
I
you.
think family matters. Can you
We'll
hear me?
just hear from Gloria first. Sorry, Gertrude, and then we'll come to you.
Sorry?
Go ahead, Gloria.
Okay. I think, especially in Nigeria, the family is very important because we live in communal ways. So there is always this tendency that you would need, if not all members of your family, but at least the ones that will give you support immediately. So I think it is very important that families from the beginning, even if it is not family, at least a friend, because I know that some of us trust our friends more than our family members. So I think a friend or a significant other, somebody that you know that will walk with you through the journey. I think from the beginning, when the journey started, a member of the family, a significant other, or a friend should be in the know, should be with the patient. It helps for emotional support. It does.
I think it's a critical safety issue, actually, Gloria, that if nobody knows what to do when there's a fever, that's a disaster. And Gertrude, you had a suggestion about how we might help those women who don't have someone to walk along beside them.
Yeah, it's very important that these women are helped, especially those who don't want to disclose to their families. It's important that we work with support groups on oncologists as you review this patient and assess what she knows and what she doesn't know. Then we should have information about the existing support groups so that you can make referrals, advocate, survivors to help these patients probably understand some of their treatment, some of the information that is given to these patients that they're hearing it for the first time. So survivors will have at least a knowledge when you talk about chemotherapy or radiotherapy. It has rung several times to the survivors' ears, so they will be in better position to explain to these patients some of the hard terms that are not easily translated into their local languages. I believe if we provide the resources and training to survivors and advocates, work closely with the clinicians to be able to help these patients, would be a good idea. That's my suggestion.
Well, I think it's a very, very useful suggestion, and they may be able to sit in some consultations as well. So if we go to when we're actually giving the knowledge about breast cancer, This work was work from Europe, from groups of women who had metastatic breast cancer and who were being asked about the importance of the language that was used to describe their condition and the ways in which that could be simply and kindly communicated. And these are things that may be different in your context, and we'll come to that in a moment. But the idea that your cancer could be treatable but not curable, that life could be extended and that you could live with the cancer rather than be someone dying of cancer. Patients sometimes say to me, when am I dying of cancer? And I said, I'll let you know after it's happened. That's when you need to know. That treatment is continuous, so it's not like a period of very intense 6 months or a year and then it's over and finished. That treatments move one to another and that symptoms can be managed, and particularly pain comes up as a symptom of great concern. Often women say in this context they feel alone, they feel that they're not visible, they're not the happy pink survivor that is fundraising for breast cancer or climbing Mount Kilimanjaro, but if they're trying to work and haven't lost their hair, they may in fact be almost invisible. What they have also told us is that jargon is of course challenging, but also some of those battle analogies that you hear, that someone's fighting their cancer or that they've lost their battle with cancer, is described as being not very helpful. The idea that we sometimes speak of that the patient has failed chemotherapy or failed hormonal therapy, when actually the hormonal therapy has failed the patient, not the reverse. It's flip the dial. And use of the word terminal is a real touch point for many patients who say, well, I don't want to know about that. Tell me, in your context, Runcie, what's a really good word to describe what advanced breast cancer is? Do you have your own good words?
Yeah, thank you very much. I mean, this is such an interesting study. In Nigeria, we had this very serious issue about who should be referred to survival and who should be referred to a patient. It was very critical because the physician or the healthcare workers community will not want to refer to anyone as survival till 5 years post-treatment. So even when we in the civil society try to refer to patients as survivors, it becomes a serious problem because they want to use the evidence-based medicine. But it's also important to understand the psychological impact of using every term on people. Labeling, it's such an important thing that it has, it can cause depression, it can bring about anxiety, it can cause a lot of psychological trauma. And more importantly, what we did was, so we want to have a good relationship with our healthcare workers community and also with the patients. So what we decided is to use the word champions. So once you're diagnosed of any form of cancer, you're just called a cancer champion. So we stay away from battling with telling you that you are a patient, so you have to be patient, or that you are a survivor, and then the doctors will have issues with them. So this also, it happens in Nigeria as well. So many patients really are very excited now when you call them champions. And once you say champions, they tell you for life, they're really excited because it brings the aura of victory, the aura of winning. It gives hope, right? Even if they're living with terminal disease, it gives hope. But we are also mindful of giving false hope, So these are critical issues, but we are working very hard to change this. Other ways we are also changing these is, is, in a way that, we are enhancing the communication among the advanced breast cancer patients beyond just, the use of the words, but also the use of images, right? So every year we try to take pictures, we organize photo shoots, and we bring cancer champions together and have a photo shoot with all of them. Have a beautiful picture of them, print those pictures, and paste it at the different portion of the cancer treatment centers at the hospitals. So when these patients come, they are seeing people they recognize, they are seeing people they know. So it creates this balance, that if this person, I think I've heard this lady before, if she can, whatever the healthcare sector is saying or whatever the care is saying, I think, living with this disease, I should be able to, to live more and have better, care going forward. Yeah.
A champion. I love that, actually. And I'm going to ask a favor, and that is that you send me one of those photographs, because I love that idea. And the other thing that we can use, of course, is images, diagrams, pictures, things that we draw for the patient. Again, might be very helpful for increasing that clarity of what we're trying to get across. Peter, do you want to comment on any strategies that you've used that have really helped with clarity, especially in circumstances where the health literacy of the patient may not be very high?
Yes, I'm learning a lot. Thank you for that. And I'm particularly struck by the fact that we use a lot of battle analogies. We talk about, let's keep that weapon for later, let's not waste our weapons, all these things, and we think we're doing a good job. And so I'm really, really thankful for this clarity for me. Now, clarity for patients. So yeah, it is. I think that the most important thing is to really talk a lot about the fact that we're going to continue treatments. So we're going to give you this, and we hope it's going to work, and we're going to try to give it as long as possible, as long as you tolerate it, and then at a certain moment we will stop, and then it can come back, or it will probably come back at a certain moment, and then we have to retreat with something else, or maybe with the same treatment. So, because if we go like we're going to give you this, and then it's probably going to take you 6 months, and then we'll see, then there is a risk that the patient will actually be put off treatment because it has worked and she's better, and then she thinks that things are over, and she will not come back until the treatment has advanced to a very to a very symptomatic stage, and then therefore we would have to obviously give chemotherapy, and very often it is very small at that stage. So I think about talking about the continuity of the treatments over the lifetime is important.
I very much agree with you, Peter, and I've heard it said today by our trainees, the idea of plan A and plan B. And the plan A, we're going to watch how effective this is, and won't that be great? And because we always watch, cancer can be tricky, we have a plan B and a plan C. And so the idea is, if you turn up for an appointment and the scan is not great, or the blood test shows something abnormal, you're not going to be dead in 10 minutes. There's going to be a plan B. And I would see that as a common fear that patients have, that, oh, I don't want to go to the doctor because one day they're going to say it's all over and there's nothing, those horrible words, there's nothing more I can do for you, which probably should just be out of our speech altogether. So moving along to emotional reactions and how we can respond to them with empathy. You're all familiar, I'm sure, with the idea of fight or flight and the adrenaline that kicks in when you are threatened. The other thing that I've learnt more about in recent times as an emotional response is the freeze reaction. And I understand from the neuroscientists that this is something that antelope do when they're attacked by lions. They play dead. They just go floppy and they pretend they're already dead, and so the lion doesn't bother to chase them anymore until it goes away, and then they get up and scamper off. And so patients sometimes can seem like they're actually taking on board what we're saying when actually they're just playing dead, as it were, and in a great deal of shock, and not much is going in. And this is where that extra person in the room is going to be so critical. So I'd like to ask you, Gloria, and also Gertrude, what sorts of emotional reactions do you think are most common in the women that you see? I've put guilt and shame here. These are things that can be culturally specific. Sometimes that sense of I've